histological analysis. Due to our high suspicion of fungal infection, we gave intracameral voriconazole and moxifloxacin injections, and to our surprise, there was a dramatic reduction in size of the lesion on post-op day 1. But the KOH mount did not show any fungal hyphae. 5 days later, there was growth of Aspergillus on SDA agar, and LPCB mount confirmed Aspergillus fumigatus. Bacterial cultures and cytology were normal, so left eye Aspergillus iris granuloma diagnosis was made, and patient was started on oral antifungals and topical moxidexa to control the inflammation. Since there was a dramatic response with 1 injection, we decided to repeat a second injection 1 week later, and over the next 3 months, we can see that the lesion completely resolved, the pupil became round, the vision was 6-6, and the eye was quiet. The medications were slowly tapered and stopped. But 10 days after stopping the medications, there was a recurrence. So due to previously documented response to intracameral vozole, we gave 2 more injections at weekly interval to reduce the size of the lesion and planned for a sectoral iridectomy this time to remove any residual fungal hyphae in the iris stroma. But the histopath and culture sensitivity were inconclusive. So we gave a 6 weeks course of oral antifungals and topical medications, and at 6 weeks, the vision was 6-6, eye was quiet, and patient was asymptomatic. But to our dismay, 2 weeks later, the lesion recurred. This time, we thought of reconsidering our diagnosis. So we planned for a lesion plus localized anterior capsular tissue excision and sent samples for aerobic and anaerobic culture, fungal culture, and histopath. And to our surprise, we found Propionibacterium acne growing in the anaerobic media, which was sensitive to Vanco, Sefta, and Moxi. Now, one might think, why did we not consider P. acne to begin with? This is because P. acne usually presents with either white plaques or a chronic indolent granulomatous type of inflammation, and this was not the case in our patient at presentation. Now we were in a dilemma. The patient's vision is 6-6. He is not ready to undergo aggressive surgery like PPP and IOL or bag removal. So we decided to do an AC wash with vancomycin this time along with moxifloxacin. And at 1 week after the wash, there was no residual lesion. We slowly tapered and have maintained the patient on topical moxidexa drops once a day. Over 3 months and 6 months, we can see there is no residual lesion, there is no recurrence. Vision is 6-6, IOP is normal, and the patient is on monthly follow-up. So what did we learn? In addition to iris malignancies, intraocular infections too can rarely present as a recurrent iris granuloma, and Propionibacterium in post-op patients and Aspergillus in immunocompromised patients can have this type of an appearance, and the possibility of a polymicrobial infection should be considered in all these patients right from the beginning, and the investigations and management is to be done accordingly. These are my references. Thank you very much.
Very nice presentation.
Thank you.
Dr. Mittal, how do you come with your diagnosis? Is it based on clinical diagnosis? When you have the differential, like fungal, you suspect a fungal granuloma?
Sir, the first time when we suspected fungal, it was based on clinical features and history. Patient is a diabetic, had a recent UTI, had a IV cannula for 7 days in situ, and then comes with a fluffy mass-like lesion, which is usually reported as a fungal ball elsewhere in the body. So we did a literature search, and we found that Aspergillus iris granuloma has been isolatedly reported from different parts of the world, and it can present like this. Whenever there's an endogenous seeding, it comes and resides on very specific part of the iris. If it was a post-op fungal seeding, there might have been some port infiltrates. The eye would have been more symptomatic as compared to how our patient presented. So our first differential was a fungal granuloma, and then the AC tab proved Aspergillus, so our treatment was dictated according to the AC tab reports.
What was the duration of the treatment?
So the first time when the patient presented, we treated for 3 months till we saw complete resolution, and we gave antifungals 2 weeks beyond the point of resolution clinically. He had a recurrence 10 days later. That time we treated for 6 weeks because we thought we had done a sectoral iridectomy and we would have removed any residual fungal hyphae load. So that time we treated for 6 weeks. But then 2 weeks later he came again with the same recurrence. So after that we did an AC wash, and for 3 months the patient had slow tapering of topical moxidexa. We did not give antifungal the third time, and now it's been 6 months. He's on once a day moxidexa and is asymptomatic.
So how can you explain on, sorry, I just skipped.
Thank you so much.